looking at capillaries, periodontal ligaments. All of these structures need to hold a tooth a lifetime. And the higher the forces in orthodontics during a treatment, the more critical the long-term stability will be in these structures. And finally, the idea came up with Dr. Damon, rather than using anchorage as an orthodontic entity, the muscles are the system of anchorage. And the idea is really very good because the muscles are the anchorage for teeth a whole lifelong. So if we think in terms of having muscles that are outside of the teeth, like the lips and the cheeks, and a muscle that is inside of the teeth on the lingual surface, this is the tongue, this is the stabilizer of our tooth arch form. And if we can use them in our treatment, how much better will our result be, and how much more stable can we guarantee for a long-term treatment result? This has caused us to not have to do extractions. Not having to do extractions does not mean we don't want to do extractions. And I've noticed that a lot of the Asian people need to do or want to do extractions because the faces just are not aesthetic the way they are. This is a completely different ballgame to needing to do extractions because we don't have enough space. So if we have enough space, it is a gift not to have to do extractions. But if we need to do extractions to create a more aesthetic result, we can do that, and we will show how stable we can achieve this with using the system. Dr. Damon was not happy with what he had done, even though it was wonderful what he had done. And he started thinking in terms of torques. And then torques came on the market. We had 3 different kinds of torques: low torque, standard torque, high torque. And just to complicate matters, people started flipping torques, using torques from the lower for the upper, from the upper for the lower, and now we don't have 3 torques, we have a huge variety, an infinite variety of torques that we have to choose from. And of course people were confused. Of course people thought, how do we handle torques? Besides torque being something that's always been difficult in orthodontics, and now it is a very complicated issue. So Dr. Damon sat and thought and worked and dreamt about perfecting torques. This was his main initiative, was to perfect and to uncomplicate torques. And one night at 2:17, he wakes up and he frightens his wife and he says, parallelogram. No, it's very difficult for people in Asia to say parallelogram. I've heard Chris Chang say parallelogram and it sounds really adventurous. So the parallelogram, together with the rounded rectangular wire, is the clue to a completely new control we have in orthodontics. And so we have what Dane was talking about, the development, the evolution of the Damon system over 30 years. So we have the 30th anniversary this year. Over 30 years, and in 2021, this was when in Europe the market received the ultimate bracket, we were able to use this bracket as well. And to give Orco some credit, I think it is remarkable that a company that wants to make money, because this is what we know the world is about, is making money. It is not being good people. It is not furthering knowledge. It is not doing good deeds. It is making money. And yet this company put its trust into Dr. Damon and took up his idea and developed, changed, adjusted, gave us a primary kind of aesthetic bracket, noticed that this was not so good, moved on to a different kind of opening mechanism, trying to get more aesthetic brackets with a new kind of material that they had on the market, and finally ending up with the Ultima system. As I said, this is really remarkable because this was developed by an orthodontist working on patients on a daily basis, like you and like me, and taken on by a company who then developed this bracket. I don't think we've seen much of this sort of thing happen anywhere else. Most of the things that are developed at universities, where sometimes the theory overrides the clinical. And here we have clinical determining what we get in our technology. We're going to look at treatment planning. And to start off with, I need to do this. This is why I didn't want this sitting here. I'm sorry, I'm going to put it here. And I don't have to walk past this because I get these horrible screeching sounds. Treatment planning is the most important factor in orthodontic treatment. This has nothing to do with the Ultima bracket or the Damon system. This is a vital part of what we do in orthodontics. Now, I have noticed that over the last years, it's become a little bit indistinct. What is the difference between a skeletal correction and a dentoalveolar correction? And I think it's very important to determine, is your patient a skeletal patient? Do you need to correct the skeletal discrepancy, or do you only need to correct a dental discrepancy? And let's see what the difference is between these two. And we know the following, this is all general knowledge, is that skeletal correction has two different directions. And I'm not talking class 1 and class 3 and class 2. I'm talking brachyfacial and dolichofacial. In brachyfacial, we have class 2 and class 3, and in dolichofacial we have the same. So we see that we have the different facial types depicting the different malocclusions. And these malocclusions can be corrected classically by a list of different approaches. We can use functional appliances, we can use fixed functionals, although I find that fixed functionals don't do a particularly good skeletal correction. We can use TADs, and last but not least, we use surgery. If I look at the dentoalveolar correction, or if I just compare the two, let's look at two cases which are skeletal and dentoalveolar. Now, both of these cases are a full unit molar class 2 at the beginning of treatment, and yet the faces look completely different. If you look at the young lad, here he is 16 or 17 years old, and the girl is 14, 13, 14, and you can see that her face is completely different to his face, even though the molar occlusion is the same. If you look at the change in her occlusion and her face after treatment, we have done something completely different in her treatment than what we did in his treatment. His treatment was done without surgery, without TADs, without fixed functional appliances, but it was done with compliance. The important thing in my practice and my experience as an orthodontist is patient compliance. If you want exceptional results, we need the patient to comply. So dentoalveolar corrections, we have two options. We have a class 1 molar relationship, which means it's just a little bit of crowding, maybe a little bit of procline teeth or retrocline teeth, but it's not really a difficult situation. If you have an irregular intercuspation, This would mean that it's either in a class 2, or in a class 3, or in an asymmetrical situation. Treating class 1 molar relationship is very simple. You do a full bond up, you just bracket all the teeth. Treatments can be finished within a year. If we look at situations where we have an irregular intercuspation, I think it is important to look, is it the maxillar spot? Is it a dento-alveolar problem of the maxilla? Or is it a dento-alveolar problem of the mandible? If it is the maxilla, we will disarticulate the mandible. We could also use fixed functions. If it is the mandible, we can use TADs, maybe to distalize teeth, for instance. Or we could consider also doing a full bond up, because I have experienced over many years that orthodontic treatment goes much faster in the mandible than in the maxilla. So we need longer treatments in general on the maxilla than we need on the mandible. So looking at treatment planning, the first question is, well, if I can do so much as an orthodontist, which are the areas that I would be working in? Well, the first area is the sagittal plane. I have to change and I have to consider sagittal facial development, and this would be incisor inclination. Sagittal plane meaning creating enough space to the anterior so that the mandible can do its anterior rotation. The next aspect of orthodontic development or orthodontic treatment is looking at transverse correction. Transverse correction is how much width do I have in the arch, on the molars, canines, to allow the mandible to be able to fit the maxilla in that anterior position, in that class 1 occlusion. And finally, we're looking at the vertical dimension, and that is the occlusal plane. Now, I know that over many, many years, for the last decades, orthodontists have spoken about the occlusal plane. Keep showing you cases where they have corrected the occlusal plane. They talk about mounting models so that we correct the occlusal plane. And yet nobody really tells you, except for Professor Sato, how to actually do the correction of the occlusal plane. And I'm going to show you today how very easy it has become to correct the occlusal plane and what we need to do to correct the occlusal plane. So I'm just going to summarize these 3 movements, and we're going to look at incisor inclination just with a little animation here. And you can see upper incisors are in the way of the lower teeth. We need to bring them forward, procline them slightly, so that the mandible has enough sagittal freedom to develop. The second point is the transverse. And the transverse is something we all know about. We do a lot of expansion in orthodontics. We start early, we work with expansion, with aligners, with fixed appliance, with alternative appliance, whether it is something like a quad helix, or a RPE, or a MARPA, whatever it is, we have done expansion to a large amount of research going into that. So the idea behind expansion is looking at the arch form of the maxilla versus the arch form of the mandible. This has always been the critical point, is understanding that we have 2 different arch forms. The mandible has a very beautiful, rounded U-shaped arch form. The maxilla often has a narrowed down and V-shaped arch form. And this means that the mandible cannot fit into that maxilla. So it blocks or locks behind the mandible in that more retruded or posterior position. So we need to create a maxilla that has the same shape as the mandible. And now watch what we do. The first thing is to look at the molars. Correct the first molar orientation into a more mesial out rotation, so that we start having an arch that has the correct shape in the posterior. I cannot create width and anterior if I keep having narrowness in the posterior arch segment. So we start posterior rotation. We then create more width in the buccal segment and especially in the canine region. So the more the canines are outward, the better the mandible can seat in a class 1 occlusion. And if you look at this, we have created quite a significant amount of space. And now we can retract the upper incisor. So this is important for quite a few of your patients. You have patients that have incisors that are too far forward, and you want to bring them back. Well, if you create good width in the posterior, you can bring the incisors back, and you can take away that full or that overfull upper lip or upper toothiness that patients have. And now the mandible will fit into this maxilla in a class 1 occlusion. And finally, we're looking at the occlusal plane. And when we look at the occlusal plane, we make one inherent error in orthodontics. And that is we take occlusion as being a fixed, final, and permanent situation. And this is not true. As you are sitting here with me, are your teeth touching? Or are your teeth apart? Can you feel the free space you have between your upper and your lower jaw? Can you feel this? Your lips are closed, but your teeth are apart. Is that right? And usually that position is not the same as occlusion is. The position where the teeth are apart can often be a more posterior downward, anterior forward rotating mandible position. Why is this necessary? The tongue wants a lot of space in the back of the mouth. The tongue is small in the front. It is big in the back. So it drops down. The mandible drops down posterior, opens up to give the tongue more space in the maxilla and the mandible in the posterior segment. I don't need to make the tongue larger in the front or space larger in the front because the tongue is small in the front. But the further back we go, the more size, volume, and space the tongue needs. So in free space, with every one of us, we have a drop down of the occlusal plane. And this drop down looks like this. That is our free space. This is what everybody does. We do not run around life with our teeth clenched together. We have our teeth apart when we're speaking, when we're resting. We only bring our teeth together to chew, to clench, and to brux. Do you know how long this is per day? How many hours, minutes, seconds we have our teeth together in 24 hours? 6 minutes on average. That's it. 6 minutes on average that we have occlusion. So to decide to treat someone with the occlusion is something that to me is not realistic. We should be treating him in his free space, in that relaxed mandible position. That should be our aim, not what we see on the model. do to correct the occlusal plane is what you see here. I have a lower splint on my patients. See that light blue little line going over the lower teeth? They are disarticulated with this lower splint. We give them a light class 2 elastic, because most of our patients are class 2. If it's class 3, that is necessary, it will be a light class 3 elastic. And we place it from palatal to buccal. Palatal on the upper, buccal on the lower. Why? Because we need to expand the maxilla. In most of the cases, we need to expand the maxilla. So, with that elastic, we have this effect that the molars are erupting because they like erupting at this stage. We have growth happening in the alveolar bone, and this eruption is creating a correction of the occlusal plane. So this is the first part of correcting the occlusal plane, is disarticulating, letting the mandible come into that free space, and then letting the teeth erupt into that occlusion. Not into the forced retral occlusion, but into the correct forward occlusion. The elastics I use here are very light elastics. We never use more than 2-ounce elastics. Very light elastics. We have bonded the upper, we're on a round wire, we do not want to use strong elastics. So there we have the 3 different planes of orthodontic effect. And now I'm going to talk to you about how this new bracket that we have on the market actually allows us to do this. So first of all, the classical bracket that we are using is a 4-wall bracket, maybe even only a 3-wall bracket with a tie wing around it, and a rectangular wire. Rectangular wires only touch a bracket at any given moment on one point. 1 point. We can only be guaranteed of 1 point of the wire touching the bracket. We're not talking active brackets because that's a different ballgame. The new bracket and the new wire look slightly different. The new wire is a rectangular wire that has a rounded edge, and that rounded edge creates what we call a tangential contact in the horizontal plane. This is what you can see on this little model here. I'm going to enlarge it. Those wires, this is the 14275 and the 18275, have that rounded edge, and that rounded form that we have in the horizontal means that the wire is always touching the base of the bracket and the door of the bracket, always touching. And this way, we have a horizontal control, because every tooth is being controlled with these points, with these 2 points, permanent contact. It doesn't matter if the tooth is tipping or moving up or down, we always have those contacts. So previously we had the play in the bracket, which is what you see here, and now we have a horizontal, perfect control. So if we look at this, this is a neutral torque bracket, and we take that 18275 wire in there, in that perfectly horizontal slot, or a parallel slot. It is still with some movement in the vertical plane. This means the patient or the tooth can still move up or down. Sometimes this is important because we couldn't place the bracket in the right position. The patient is younger. We want to have 5s growing, but they haven't come out as much as we need them to. So the bracket isn't placed quite in the right position. So to have a little bit of vertical play, sometimes it is good. The other play that we have is the rotational slot play. And rotational slot play, you can see in this little model here, shows us we have no torque control. There's no torque control. This bracket doesn't do torque control. It does horizontal control. It can also do some angulation control, perfect angulation control, but it doesn't do any torque control. We have some more brackets. We have a procline, and we also have a retrocline bracket next to these neutral torque brackets. And these three brackets are used in different zones of the dentition. Basically, the procline and retrocline torque brackets are used from 3 to 3 in the upper, 3 to 3 in the lower. And the neutral torque brackets are used in the posterior segment. Now, I've written up some exceptions in the lower, in the neutral torques, to show sometimes when we use a different torque on an anterior teeth beside procline and retrocline. And we will see this when we look at the examples. You have it there with you on your PDFs that I've sent you. So let's look at what the difference is between procline and retrocline, because we're not using neutral torque on anterior teeth. So now we don't have 3 or 6 or 150 different kinds of torques because of all the combinations we used to have. We only have 2 torque choices. This makes it infinitely more easier to do our treatment. We're only looking at 2 different torques that we will take, and it works every time. So first of all, I'm using this little slide from Dr. Damon and from Steve Ward to show what exactly is the difference in the construction of this bracket and the wire. Previously, we had that rectangular wire that just fit into the slots, one contact at any given time, and this tooth might contact here and that tooth might contact here. So you'd have a very random kind of control in orthodontics. Now we have brackets that have 4 points of contact. We have that horizontal control through the rounded form of the wire, leaning against the base and the door of the bracket. And added onto that, because we have a parallelogram, we now have a vertical control, and that is our torque couple. In the procline bracket, it has this direction. In the retrocline torque bracket, it is the opposite. Let's see how this works. So I have a retrocline tooth that gets a procline torque bracket, and I have a procline tooth that gets a retrocline torque bracket. I'm pretty sure that we're all familiar with the choice that I have here. When we put the wire into the retrocline tooth bracket, we have to deflect the wire to make it fit in the bracket. And that deflection is the action, or is the activity the wire will now translate onto the tooth. With the procline tooth, I deflect in the opposite direction, and now we have the force in the other. The force direction, or the translation of force, is now proclining in the procline torque bracket and retroclining in the retrocline torque bracket. But look very carefully at the results. Proclining torque bracket will finish the tooth at 7 degrees, and the retroclining torque bracket will finish the tooth at 7 degrees. 7 degrees to the occlusal plane. Now, Typically they say 7 degrees to the Frankfurt horizontal, but this is not possible because we do not have the Frankfurt horizontal as a reference in the treatment. The brackets, the teeth, are always connected to each other, so the reference will be the occlusal plane. Now, you can see that the wires look like they're not fully leveled out with the buccal segments. This is why we have this little wire sitting in the front here. This is telling us what the level of the wire is in the buccal segments. I'm enlarging this for us to see what happens now. So the final bit of action of torque of the bracket and the wire moves the wire to be completely level with the buccal segments, and now the wire hits the torque couple, hits the 4 points of contact. And at that point, no more movement happens. Same happens on the retrocline torque bracket. As it levels out onto the level of the buccal segments, we get it hooking on and creating those 4 points of contact. Now 4 points. Why 4 points? Why did we not think of 4 points many, many years ago? How safe would you feel on a chair that has 2 legs? How safe would you feel? Would you like to sit on a chair with 2 legs? No. Four legs. Stable. This is what we have done in orthodontics now, is we have created a stable contact situation. Now the interesting thing is, why procline and retrocline if they both give me the same result? Because if I look at the procline bracket, and remember, that tooth was retroclined at the beginning. This tooth was in a retroclined position. So I had to put a procline torque bracket on, and now, if I want to, I could procline the tooth more with that bracket and that wire. Did you see the movement freedom in the bracket? Look at the other one. Look at the retrocline. Can you see the space above, anterior above, posterior below the wire? Well, that space means the tooth could still move in that direction. Okay? So this bracket would allow us to retrocline, and this bracket would allow us to procline. Sometimes we need more proclination. Sometimes we need more retroclination. And the bracket would allow us to do this, but it will protect against the other direction. A procline torque bracket protects against retroclination. So if you put a procline torque bracket on a tooth, that tooth will never retrocline. This is important. You put a procline torque bracket on a tooth, that tooth will never retrocline. Cannot. Because of those 4 points, they stop it. And the opposite is true for the retrocline torque bracket. It can only cause retroclination, it cannot cause proclination. So let's think of one of your patients. Bimax protrusion. You don't want the teeth to go forward. You put a retrocline torque bracket, and you can be sure that tooth will not procline. You put a retrocline torque bracket. Okay, I will show you lots of different cases, but first of all, I want you to understand, how do I decide which bracket? Do I use a procline? Do I use a retrocline torque bracket? So previously we had to, in our treatment planning, think about all these things. We'd have to think about the tooth position, the mechanics, the torques, the angulations, the rotations. All these things would have an effect on the way the front teeth were positioned and what torque I would have to take. This would make choosing torques extremely complicated, especially if your choice of torques was a huge one. So everybody was sitting there thinking, what am I going to do? Especially the young orthodontists. So choosing a bracket was a really difficult situation. But now, all we need to do is we need to think, where do I not want that tooth to go? Look at the tooth and you say, where may it not go? You have a procline, Bimax procline situation, you will say, I don't want it to procline. You put a retrocline torque bracket. So you look at the tooth and you don't think about mechanics, you don't think about anything. You just look at it and you say, I don't want that tooth to procline. Retrocline torque bracket. You will end up having a pretty standardized torque prescription. This doesn't mean standard torque or neutral torque. This means you have a choice of torques, procline and retrocline, that you will put in your patients that is pretty standard. You can prepare a lot of them because your patients will come in, they will always need that prescription. So important, where may the tooth not be is your question, and you choose the torque in the opposite direction. And as I said, most of your cases, you'll find that you need a standardized prescription. So let's look at some cases. Here I have a typically European case, a patient with a class 2 Div 2. You can see that upper arch, typically narrowed down. Molars are mesial in-rotated. The arch collapses to the anterior of the upper arch, and we have that slightly V-shaped arch in the maxilla. The mandible on these patients always looks beautifully U-shaped. What torques am I going to place on her upper incisor? What do I need to do for her to come out of the class 2? I have sagittal, I have transverse, I have occlusal plane, I have vertical. What torque? I need to bring those incisors forward. In her case, I don't want the incisor to go backward. Because if that incisor goes backward, it will push the mandible backward. You understand? So I will place a procline torque bracket on that upper incisor. On the canine, can you see how narrow the arch is at the canine? The intercanine width is not enough in the maxilla. The lower intercanine width will be wider than we have in the upper. So I need to bring that canine out. I will use a procline torque. Okay, is everybody with me? Do you follow the reasoning that I have? Does this make sense for you? Canine procline torque. If I put a procline torque on the upper canine, it will help transversely expand the arch, because the canine coming out will bring the premolars out as well. The only tooth I don't need a procline torque on is the lateral incisor. Lateral incisor is flaring. And in our patients, we often see the relapses on lateral incisors is flaring. Upper lateral incisors. Post-treatment, they go back and flare. So we place a retrocline torque. That is my torque prescription. Okay? Do you understand my thoughts? I look at the incisors. Where do I not want that tooth to go? I don't want it to go backward too much. The canine, I want to bring out. I don't want it to become narrow as I do class 2 mechanics. So I put a procline torque on both of these teeth. And the lateral incisor is flared. I need the root to come forward. A retrocline torque will bring the root forward. Okay? In the lower, for class 2s, the big problem with lower teeth is class 2 mechanics like to procline lower incisors. I don't want to procline lower incisors because that means if they procline, they will knock against upper incisors and the mandible will pull back. Back in class 2. So I need the lower incisors to stay upright. What torque? And again, canine, I give a procline torque because it helps upright the arch. It gives me enough space for front teeth, for anterior teeth, to fit into if I upright the canine. And often we see canines that are doing this in the lower arch. So we choose this torque. Now in Europe, this is our classical standardized torque prescription. This will not necessarily be the Vietnamese torque prescription. You have slightly different faces. The result of the treatment looks like this, and the treatment took 14 months. Only 14 months of treatment. Why was the treatment so fast? Because we have control. Because we don't have to do wire bending correction, auxiliaries, torquing appliances. We don't need to do all these extras because we have a bracket that controls in the horizontal plane and in the vertical. You can see the arch before and after. We had some molar out rotation, canines came out, premolars came out. And that has given me that perfect arch shape. What about this patient? He has an overjet of 16 millimeters. He is 17 years old, and he is a massive skeletal class 2. That's his profile. Now, if you look at that profile, people will always see the discrepancy between the upper and the lower. But many people don't look at what does the upper lip and the nose look like. And you see that his upper lip and nose don't need extractions. They don't need me to bring him backward, because then his lip will be behind the nose. His nose will look like a beak. He will not look good anymore. So I need, in this case, to keep the upper incisor forward. So my question is, where do I not want that tooth to go? I don't want it to go back too much. Which torque? Understand? And the lateral, I do the same. I give a retrocline torque because I find that the roots of the laterals don't always do what they are supposed to do. So I bring the same torque prescription for this patient as for the one before. Lower incisors, retrocline, because if you look at them, you can see they are procline. I need to retrocline. Question, where do I not want the tooth to be? This gives me this prescription. And the result of his treatment looks like this. No surgery, no TADs, no functional fixed appliance. He only did orthodontics. I put him on a disarticulation that allowed his mandible to come away from that retruded mandible position, and then he started growing at the age of 17. Now, this is unheard of. In orthodontics, we always thought a mandible finishes growing at 13 years old. Well, it actually finishes growing its mandibular body, the length of the mandible, where the teeth are sitting in a horizontal, finishes growing 90% at the age 1, not 30. Finishes growing much, much earlier. But the vertical growth, we all know, we cannot place an implant on a patient that is 17. We don't place implants. We have some people here from Noble, and I'm pretty sure they will tell all of the dentists amongst you that do implants, don't place implants on a young patient. Place implants at the age of 25, 26, 30, but not 17. Why? Because we have alveolar, we have vertical facial growth. And that happens in the mandible, in the ramus. And that ramus growth is exactly what we need for him to rotate, to bring the mandible into a forward rotation, not forward posturing. That's a different thing. That is his upper arch result, and if you look at the upper incisor, you can see the upper incisor protruded, even though I used a procline torque bracket. The upper incisor protruded because the procline torque bracket will make the tooth end at 7 degrees, same as the retro. But if I wanted to, if I had put in class 3 elastics, now do you think I would put a class 3 elastic on a class 2 patient? But class 3 elastics procline teeth, right? They procline upper teeth because they push the whole arch forward. We're not going to do this here. If I put oil springs between his teeth, I would procline teeth. I'm going to do this either. So his teeth will not procline. They will finish at the perfect position. Look at the change in his face. This is where he started. Saw this patient earlier on. So we get a skeletal correction, not just a dentoalveolar correction. We can do skeletal corrections with orthodontics if we understand the 3 planes of orthodontic movement. Sagittal, open up. Transverse, open up. Occlusal plane, drop down. Steep to flatter. The flatter the occlusal plane, and this is what Professor Sato has said for many years. We know it from biomechanics. We know it from Charlie Burston, Ron Roth. All the great names, the old great names in orthodontics have spoken about changing the occlusal plane, making the occlusal plane flatter to get a stable result. Not Sunday bites, not forward pulling of the mandible, but rotation. Well, this is a very European patient, but you might have patients that are missing laterals. Now, if I was living in Asia and I had a patient with missing laterals that has a bimax face, I would still not close the spaces because I want canines to be in the right position. I don't care about laterals. I care about canines. Canines have to be in the right position for a correct gnathological function. And if I put a canine in a lateral position, it has no function at all. So I would probably end up opening a space for the lateral and extracting a premolar rather than closing the space. So this patient wanted orthodontic treatment, and they had said to him he needs surgery. But I'm not sure what they wanted to do with surgery, because he has a perfect class 1 molar relationship. Can you see that? Perfect class 1 molar relationship. What are they going to do with surgery? I think he's a pretty orthodontic case. Can you see his upper teeth are retroclined? So what torque am I going to take? Procline. In the lower, look at those lower teeth. Can you see that they are retroclined? But as they start aligning, they're going to do what? They're going to come forward. So the question I ask here, you can see, has a very tight bite. The question I'm going to ask is, where do I not want the teeth to be? And I don't want his lower teeth to come forward too much. Same question. Always the same question. I don't want them to come forward too much. I am not afraid that these teeth are going to retrocline. Can you see that? Are you afraid that those lower incisors would retrocline? No. So I put a retrocline torque bracket on them. Because I don't want them to procline too much. Retrocline torque bracket. This is his result. He has the implant in place with a crown on the lateral incisor, and this is the change in his face. Now look at the difference in this man's face. He looks terrible at the beginning. He looks frightening. And he looks much more pleasant and aesthetic at the end of his treatment. What about class 3s? Now I think you have quite a few class 3s here, is that right? You have a lot of class 3 patients? Well, if we have a class 3 patient, we have to think the other way around. Because orthodontics likes to procline upper incisors too much, retrocline lower incisors too much, and then the patients have a very unhealthy incisor situation. Unhealthy because the bone doesn't like teeth that are lying down. It wants straight teeth. So if I look at this case and I say, where do I not want the teeth to go? The upper teeth must not procline too much. The lower teeth must not retrocline too much. I will choose the opposite torque. I will choose upper retrocline, lower procline. And in her situation, I have something else I want to look at. Can you see the roots and the bone labial of 4-1 and 3-1? Can you see how critical that bone looks there? Now if I use a retrocline torque bracket, that tooth will not protect the roots from going forward more. But if I use a procline torque bracket, I can bring the root back into the bone. See the result? Much better. Now what about a patient that we do extractions on, or that has lots of spaces? What torque would we take on a patient with a lot of spaces? Look at the question, you look at the patient and you say, where do I not want the teeth to go? And you're going to be doing retraction mechanics. You're going to be space closing mechanics. So you're thinking, I don't want the teeth to go back too much. I want the root to stay in the right position. What torques? Torques am I going to take? Procline. See that? So extraction cases, space closing, you need procline torque brackets. And he gets them everywhere. Procline upper, procline lower. Because we need to close spaces everywhere. Look at the spaces he has between his teeth. And I gave him a procline torque bracket. And look at the result. Those teeth look like they could be a little more proclined. Can you see that? They do not look like they are proclined. Procline torque bracket to prevent too much retroclination. What about a patient that is open bite? Now look at the open bite patient and see what is going on over there. Can you see the bone on those lower incisors? You see the bone on those lower incisors? The question is, where do you not want that tooth to go? You don't want it to go backward, because otherwise the root comes completely out of bone. You want the root to stay forward. So the torque on the lower is going to be procline. That's it. Okay? Just a procline torque bracket. In the upper, you look at this, and you say, I'm going to be using closing elastics. Closing elastics pull teeth backward. So the same question, where do I not want the upper teeth to go? I don't want them to go too much backward. Because you know, open bite patients, sometimes they are gummy. You see this? Gummy patients? Now if I have a retroclining tooth, the crown goes backward, the root comes forward, and then I have a lot of gum. They don't look good. So I use a procline torque bracket to prevent the root from doing this and prevent too much retroclination, too much gummy. So the torques I take on this patient are procline, except for the lateral incisor. Can you see why the lateral incisor gets a retrocline torque bracket? Because that incisor, that lateral incisor, you can see it here. Look at the gum on that lateral incisor. Why does the gum look like this? Because the crown is doing this, and the root is back. You've got lots of gum here. We need that lateral incisor root to come forward. The root needs to come forward. So as the root comes forward, I use a retrocline torque bracket. Retrocline makes the crown go back, the root come forward. This is why we need a retrocline. And in the lower, we've already spoken about it, we do a procline torque bracket choice. And this is the result on this patient. Patient with massive crowding. She does not need extractions. She has a very flat face. This is different in your patients. You might want to do extractions in these cases. But if you see the face looks good, you can do this kind of treatment, also in Vietnam. If you use the right torques, the case will not go wrong. Now in this case, because the patient had a flat face, I gave her a procline torque on the upper. If the patient does not have a flat face, if she has more volume in the face, then you give her retrocline torque. You don't want the space creation that we're doing here to procline that upper incisor too much. So you might want to place a retrocline on the upper centrals. In her case, this was not necessary. In the lower, we place retrocline to prevent teeth from proclining too much. Question, where do I not want the tooth to go? And this is how I choose the torques. We're going to see more of her treatment later on. Now we're going to look at a biprotrusive patient. This patient has his teeth all forward. Now in Germany, people don't want to take out teeth. This is different in Asia. People want to take out teeth here. But in Germany, the mothers, they don't want to take out teeth. So this patient, they said, don't take teeth. Leave the teeth. What torques am I going to take in that phase? If I leave the teeth and bring the crowns backward. So I take a retrocline torque, upper and lower, except for the canines. Because if I take retrocline canine, it's going to make the arch narrow, push the front teeth forward. I need the arch to go wide because more width here means flatter teeth in the front. You understand? This is important for you because your patients, if you're not doing extractions, you need width to get flatter in the front. So canines are procline and the incisors are retrocline. Look at this patient. She has a retainer that is made from a twist flex wire. And this retainer starts, she is 34 years old. And this retainer is starting to unravel. And because of that, her teeth are starting to do this. Can you see that? She was at 6 other orthodontists. And everyone said, thank goodness you have a retainer. And she came in my practice and I said, we have to take out the retainer. The retainer is doing this. I think you don't see this. You don't have these retainers, right? You don't see this sort of thing happening. Is that right? Okay. But we see quite a bit of this happening. So I sent her to periodontal surgery. 1.5 years later, she comes into my practice for treatment. What torques do we take on her? Now, can you see the critical teeth? A critical tooth is 4.2 and 3.1. I am afraid of these teeth. I don't know how I'm going to save these teeth. Here is the exception. I place a neutral torque bracket on the teeth. I don't want any torque. But I can't place neutral torque on all the teeth because then I have no control. Only on those two, I place neutral torque. And the other teeth, I give them the right torque. So the lower canine here that is proclined gets a retrocline torque because it's doing this. And the other canine that was lingual, I give a procline torque. So that I upright both of them. The one more in, the other one more out. Incisors, I gave a procline torque because I wanted the roots to go into the bone. Don't want the roots to come out more, like on 4.2 and 3.1. Going to see her results later on because I have her as a case presentation. Where do we bond the bracket? Now it is really important. The bracket, the parallelogram, the 4-point contacts were designed for the center of the tooth. We call this FA point, facial axis point. So if you place the bracket in a different position because you think it looks more aesthetic, or you think you need to close an open bite, or you need to correct a deep bite, it doesn't work. Do not place the bracket in a different position. Keep that position because the torque was designed for that position. I'm showing you now what happens if I place the torque of that tooth on a different position. I'm using a procline torque bracket. Procline torque more incisal will make the tooth proclining. It becomes 8 degrees more torque. You might not want this. If I place the bracket, but I'm talking about a procline bracket, procline torque bracket, more gingival, it will retrocline the tooth. And now, 7 degrees that I wanted becomes -2. This is not a good idea, because now you will lose control over your treatment. So place the bracket on the center of the tooth. This is what it looks like. When we place the brackets. And here you can see this is a typically European bracket choice. We have procline on the upper canines and the lower canines. We have procline on the central incisors, and we have retrocline on the upper laterals and the lower 4 incisors. This is our standard torque prescription in Europe. But our faces are flatter, so we need this. You will need a prescription that is more retrocline if you don't do extractions, and you will need a lot of procline if you are doing extractions. I told you that we're always taking, and you might have seen all the pictures, every case I showed you had procline on the canines. And this is the reason why. Because I have to bring the crown out, otherwise you get these long canines. They look like vampires. The more the root comes out, the more you will see gingival exposure, or tooth exposure. So we want that. We want the crown out and the root in. We want to get a good transverse development. And if you bring the canine out, the buccal segments will also come out. And of course you want to create space for incisors. So if you bring canines out, more space for the incisors when they are crowded. So that's what you see on that little animation. The crowns of the canines coming out will upright the buccal segments. Watch the slide and you can see the animation that I have here. Lower canines, crowns out, then buccal segments will upright properly. We see this on the left and the right hand side. And now we can see there's more space for those lower incisors to align properly. So we can resolve the crowding better without getting proclination. This is the result of the treatment. No extractions, but of course remember, this is a European face. So in her case, we needed to keep her teeth. Now you can see that her upper incisors, I didn't put a retrocline torque bracket on her upper incisor. I put a procline torque, and they do not look proclined. Can you see that? They finish at 7 degrees. Why do we always use a procline torque bracket in a class 2 patient? So we're going to talk about class 2 and class 3s now. And I'm going to take you through what to do, how to treat a class 2, and I'm talking skeletal, class 2 patient, and to get a beautiful result on him if you follow these steps. Now if we look at a class 2 patient, class 2 patients usually look a little bit like this. Upper lips are forward, lower lips are backward. Sometimes they are biting on the lower lip. Upper teeth are in front of the lower lip. Now we would like them to look like this. We would like them to have a straight face. But usually orthodontic treatment, with the mechanics that we do, long class 2 elastics, it does this. It pulls the whole face backward. The chin is backward and downward. Now we have a class 1 occlusion, but we don't have a class 1 face, because now the patient looks like this. These patients have problems with temporomandibular joints. These patients have problems very often with airways, with breathing, sleep apnea, all these things. If I place a procline torque bracket, I can keep that upper incisor, okay, I'm just going to finish the class 2s, okay? I can keep the upper incisor forward, up. If I have a procline torque, I am preventing the elastic from pulling the whole incisor and the bone of the incisor downward, making a gummy smile. So with a procline torque bracket, I am stabilizing the incisor forward, upward. And that will help correct the occlusal plane as well. So these are the points that we have as a benefit if we use a procline torque on class 2 patients. If you need to do extractions, you will still use a procline torque on the upper with your extraction patients. The second point is, where do I place the turbos? Now remember, class 2 patients very often have an occlusal plane that is quite steep. I need to correct the occlusal plane, which means I want the incisor to go up or stay up. I want the molars to come down. If that happens, I have a much better mandibular forward positioning. How do I get this? I won't get it if I place a turbo posterior. I need to place the turbo anterior. So the anterior turbo is important for a class 2 correction, so that the patient will intrude the upper incisor and allow posterior teeth to come together. You know, if you take a class 2 case and you tell them, push forward into class 1, the bite always opens on the back teeth. Have you noticed that? Does this happen here as well? If you say, patient, push forward, mandible forward, posterior teeth have no occlusion. We want posterior teeth to grow together, even in divergent patients. I will show you cases and you will see, even in divergent patients. So the turbo will allow the posterior teeth to extrude, and that will correct the occlusal plane. If you put the turbo posterior, you're intruding posterior teeth, you have no control over the occlusal plane. So you always, on class 2 patients, always, doesn't matter whether they class 2 div 1, class 2 div 2, you always place the turbos on the anterior teeth. Now finally, with a class 2 patient, we still need to think about elastics. Now here we have a class 2 patient. She has quite a bit of an overjet. She also has a bimax protrusion. Not as bad as probably a lot of your patients, but we have a little bit of bimax protrusion here. And she finishes off with a situation like this. Now you can see the upper incisor has retroclined. The lower incisor has retroclined. So her bimax protrusion is less. What torque did I take in the upper? Because she's class 2. I took a procline torque bracket on that upper tooth. Even though she has a proclined upper incisor, I give her a procline torque bracket because with class 2s we need to do procline on the upper incisors. Look how that changed from the original incisor position. This is, you watch the screen and you can see the animation. That is where the incisor would have been, where you think it would go with the occlusal plane correction, and it did not procline, it actually retroclined. And you can see that with the way the incisor is sitting there in the background. So even though I took a procline torque bracket, the upper incisor retroclined to 7 degrees, because that is what the bracket has programmed in. 7 degrees is the perfect end position. And to get this, we don't place long class 2 elastics, because long class 2 elastics do not correct the occlusal plane. They always make the occlusal plane worse. If I pull an elastic on the front to the lower bottom, I will pull the anterior teeth down and I will lift the posterior teeth up. In the front on the top and the back in the bottom will pull the lower posterior teeth up and drop the anterior teeth in the top down. That makes a steeper occlusal plane. But I want a flatter occlusal plane. So I need a short posterior elastic. I want to bring posterior teeth down. A short posterior class 2 elastic. This way we can correct the occlusal plane, make it flatter, and you can also use a box class 2. So you can see here we have this short posterior class 2. This could be upper 4 to lower 6 or upper 5 to lower 7. I use both of these variations. But even better, I prefer this. 4 and 6 in the upper, 5 and 7 in the lower. Box elastic. Don't use a canine. Leave the canine out of the elastic, because you're going to have to pull the whole upper alveolar bone down like this. Don't want to do that on a class 2 patient. And we will talk about the class 3 when we come back from the coffee break, because I think there is a coffee break now, and it would be great if we could be back in about 20 minutes. Is that okay? Thank you very much.
Yes, thank you, Dr. Menka, so much.
What we're going to do